Today's Coffee with Carrie, I want to talk a little bit about the telehealth and telemedicine billable codes and really kind of break it down quite simply. Um, there's several different buckets that are currently reimbursable today, and it's a little bit tricky, so I want to go over a few things. I've made a few notes, which I usually don't do, but the first one I want to talk about is really the commercial insurance side. So depending upon this is really depending upon what type of insurance plan the patient has. A lot of the large insurance companies have really seen the benefit of telehealth and cover telehealth depending upon the type of plan. So if you look at, a Blue Cross Blue Shield, an Aetna, Cigna, United, all of those guys are covering telehealth. It is policy dependent, so you need to check the patient's policy. But it's pretty straightforward from a reimbursable code standpoint. It does require a two-digit modifier, which is 95, and 38 states have guidelines on the telehealth reimbursement. The second category I want to talk about is really private pay, more of a convenience fee, no insurance. So some companies are charging anywhere from $30 to $75. It's cheaper than a copay, cheaper than going to the ER from that perspective, but it really helps. If you're a mom and, or even a business professional and you'd rather just pay the fee than have to go wait somewhere at a minute clinic or things like that. Some companies are charging that and not even hitting the insurance. So that's a possibility as well. Medicare is the most complex by far. Their codes and requirements for telemedicine really include online evaluation management, and it hasn't been updated since 1995. So there's a lot of changes coming that way, but currently there's two parts. One is the coding side and one is the eligibility side. So you have the standard code and then you have a modifier. So there's multiple modifiers, either O2, GQ, or GT, and there's some constraints. So you have to have the healthcare provider as the distance site and then the patient from an originating site. So the originating site does have to be, there's 7 qualifying categories, and it really has to be in a health shortage area. So think rural demographic. From that perspective, it has to be done by a physician, a nurse practitioner, someone of that nature. And there's also some guidelines around chronic care management and remote monitoring that offers some areas of opportunity there as well. So really want to look into the originating site and the distance site and see how that applies. On the Medicaid side, this is very much like the commercial insurance side. Very same principle, using the GT modifier, available in 49 states, and 10 states allow the home to be originating site. So that's very important. That's a big difference from Medicare. So in Medicaid, you have Delaware, Colorado, Maryland, Michigan, Minnesota, Missouri, New York, Texas, Virginia, and Wyoming, where a home can be originating site. So there's been a lot of stuff lately on the new billable codes that are coming from the federal side on January. So each state has passed different laws and legislation on new codes that are coming. However, on the federal side, there's some new and exciting things coming. So I just want to rattle off a few. One we've heard a lot about is dialysis. So, a lot of folks, I think it's the numbers now are like over 30% of people are doing home dialysis, which causes a little bit of a challenge for doctors and nurses and so forth to go to the home. And so there's going to be some new billable codes for those monthly at-home visits and check-ins on infections and wound care and things like that. So that's very exciting. Provider-to-provider consults. So, you go into a doctor's office, you need the provider has some questions for a specialty provider, and so there's going to be some billing availability there. Patient assessments. So they're going to cover the ability for check-ins that's going to ultimately lead to an in-office visit. So that's good. Stroke services. That's been, covered a lot, and a lot of telehealth has been used that connecting hospital to hospital, rural hospital to big city hospital, and so that will continue. Um, Chronic and transitional care, so really getting more proactive on that side, through remote monitoring and follow up visits and things like that, to really prevent folks from going back into the ER, from that perspective. Mental health, which is really exciting to be able to remotely do, mental health, video assessments, and follow up care from that. More site availability. So, hospitals, there's some new guidelines coming on hospitals that are rural counties, have less than 25,000 people, more guidelines from that perspective. And then one I think is going to make some big moves, which I'm pretty excited about, we're doing a lot on, is really substance abuse treatment. So that removes the originating site, and especially on the Medicare and Medicaid side. And so, really, this opens up a lot of opportunity for people not repeating to go to rehab and repeating to go to addiction centers. And so, really, that kind of aftercare and so forth. So, a lot of new things coming down the pike. Start with what you can kind of do today. Not only think about the billable side and the revenue side, also think about the operational efficiencies. And then really keep your eye on your state and what's coming in January will help you really shape where you need to be. You should already have your technology in place. If you don't, that way you'll be ready for January 1. And that's today's Coffee with Carrie.